Buenos días. Vamos a abrir las sesiones plenarias de esta mañana. Good morning and welcome to today's plenary sessions. This session will be chaired by Dr. Rafael Delgado from the Microbiology Department in Hospital 12 de Octubre in Madrid, and myself, Inés Suárez García, from the Internal Medicine Department in Hospital Infanta Sofía in Madrid as well. We're going to have two talks, and we will have a short time for questions after each talk. And for the first session, let me introduce to you Dr. Andrew Hill. Andrew is a senior visiting research fellow in the pharmacology department at Liverpool University. He has done extensive research on antiretroviral therapy, specializing in clinical trials and access to medicines. He has done the advanced clinical trial, which, as you all know, was the first study to raise concern about weight gain among people starting antiretroviral therapy, and which has given us lots to talk about in the later years. Today, he will talk to us about assessing the weight of the evidence 4 years after ADVANCE. And Andrew, thank you very much for coming. We're very happy to have you here.
Good morning, and thanks very much for inviting me to present at the conference today. So I was working on the ADVANCE trial 4 years ago, and I'm just going to go back. And I presented at the European AIDS conference 4 years ago with this idea about what was driving weight gain. And every year we learn more and more about this. In the ADVANCE study, in the early days, we didn't expect to see this weight gain. We had people who were doubling their weight. We had people who got so large, we had one set of scales that went to 130 kilograms. When people went over 130 kilograms, we had to put them on 2 sets of scales. We had people, as I said, doubling their body weight, and some of the patients got so large that the doctors didn't recognize them in the waiting room. It was that bad. Now, we thought at the time that it was dolutegravir that was driving the weight up. Before the study started, everybody in South Africa was taking efavirenz with TDF. So we thought it was the dolutegravir raising the body weight, that protease inhibitors raised it, and perhaps tenofovir and efavirenz could lower it. I'm going to go through each of these arrows this morning and update you on what we've learned since then. So the weight gain got so bad in ADVANCE that the ethics committee nearly stopped the study. We had to find out what was happening. Early on, we found out that women were gaining more weight than men, and other studies were showing that black people were gaining more body weight than either Asians or Caucasians. And I'll just show you some of the evidence around that that's been accumulating since. So you can see this data from the United States, a cohort study, women taking protease inhibitors or women taking integrase inhibitors gaining more weight, twice as much as weight as men. And also in the same cohort study, black people gaining more weight when they took integrase inhibitors than either Hispanics or non-Hispanic white people. Same trend seen with protease inhibitors. Now, in the ADVANCE trial, when we looked out to 4 years, on the left-hand side, you can see the weight gain in the females, and particularly people taking TAF, FTC, dolutegravir, gaining a mean of 10 kilograms over 4 years, and then the males gaining less weight. And you can see TAF, FTC, dolutegravir gain more weight than TDF, FTC, dolutegravir, and the lowest body weight gain is with efavirenz. Now, this translated into a higher risk of clinical obesity over time. So this is a body mass index above 30 kilograms per meter squared. And you can see the women over time, of the people taking TAF, FTC, dolutegravir, about 40% becoming obese after week 192. But the males are far lower risk of clinical obesity. Body composition, so you can see this body weight is, a lot of it is trunk fat. Now that's in the orange, and you can see that the women gain more trunk fat than the men. And then you would not be so worried about a gain in lean body mass, but it's this trunk fat that is a particular issue with central adiposity. Taking it one stage further to metabolic syndrome, which in this definition is the combination of clinical obesity plus either raised triglycerides, reduced HDL cholesterol, hypertension, or hyperglycemia. So central obesity and any two of those, you can see here that the women are at a particularly high risk of developing metabolic syndrome. 1 in 5 of them develop metabolic syndrome taking TAF, FTC, dolutegravir, and smaller proportions taking TDF, FTC, dolutegravir, or efavirenz. So the difference between men and women is very clear. The difference between blacks and whites is very clear. When we get to hypertension, we saw in advance that the people taking TAF, FTC, dolutegravir were significantly more likely to develop hypertension during treatment. This was also seen in the NAMSAL trial comparing dolutegravir with efavirenz. So I don't know, to be honest, whether hypertension is completely linked to weight gain or is an independent mechanism. If you look at all the different studies of hypertension, there are some studies showing higher risks of hypertension for dolutegravir versus efavirenz, and we need to remember that ViiV did not measure blood pressure in many of their studies, so they don't have a large database to answer this question. They also didn't weigh people in a lot of their studies, so that we actually have more data on body weight and hypertension than the ViiV studies. So hypertension, the good thing about it is it's very easy to treat, and there are cheap antihypertensive drug options available for tiny amounts of money, less than $1 per month. Now, if we then go on to the drugs, which drugs could be driving weight gain and weight loss? So we saw the smallest weight gain when people took efavirenz. Now, there was pharmacogenomic work done in the advanced study looking at people who are either fast or intermediate or slow metabolizers of efavirenz. And the people who are slow metabolizers, it's a genotype that's seen more among black people, and the drug tends to have much higher concentrations for these people. Now, what we found was that the people who are slow metabolizers had the smallest weight gain. So they've got a very high concentration of efavirenz. There are different possible mechanisms how this could work. It might be that there's a concentration-dependent toxicity to mitochondria, adipocytes, or it could be that the CNS side effects of efavirenz are just making people have a less appetite. We don't know that. But the people in advance in the efavirenz arm were weighed and genotyped. And what we found if you look at the people who are slow metabolizers of efavirenz, now that's the group in the light blue, and you see the females, they actually lost weight during the advanced study during the first 48 weeks. And also the males who are slow metabolizers, they got this very high concentration of efavirenz. And then the intermediate metabolizers gained a little bit of weight. And then the people who extensively metabolized efavirenz, so they cleared it more quickly, they gained about the same amount of weight as people who were taking tenofovir, FTC, dolutegravir. So instead of dolutegravir raising body weight, this evidence suggests that efavirenz is somehow lowering body weight. So the difference between efavirenz and dolutegravir could be because efavirenz is lowering body weight instead of dolutegravir raising body weight. But I don't really want to talk about efavirenz much longer because nobody uses it. It's not even used in Africa. The vast majority of people in Africa are taking dolutegravir because it has fewer CNS side effects, there's a lower risk of rash. We still don't know about hypertension, but there's a lower risk of drug resistance, lower risk of liver enzyme elevations. So I think from now on I'm going to concentrate on the second piece of the jigsaw, which is TDF versus TAF, or actually TDF versus no TDF. So this was the next analysis that we looked at in a lot of detail. We looked at HIV positive and HIV negative people here. So there was a large analysis of the Gilead studies authored by Paul Sachs in Clinical Infectious Diseases, showing that people who took TAF-based treatment tended to gain more body weight than people who took pretty much any other nucleoside analog. We looked at TDF versus placebo in the original studies of HIV-negative people on pre-exposure prophylaxis. And among 7 PrEP trials in over 19,000 people, there were significantly more reports of weight loss for people taking TDF versus placebo. There was also a significantly higher risk of vomiting for TDF versus placebo, but no differences in nausea, diarrhea, or loss of appetite. We published it 2 years ago. So that suggests even if you take HIV infection out of the equation, that TDF itself seems to be driving a form of weight loss. Now, if we then look at TDF versus other drugs, so in the Discover study, which was, again, HIV negatives, and taking either TDF-FTC or TAF-FTC, the people taking TDF-FTC gained no body weight during the first 48 weeks. People taking TAF-FTC gained 1 kilogram. TDF-FTC versus abacavir, a lower body weight rises. TDF versus TAF with darunavir, cobicistat, lower body weight rises. And Gemini, if you compare TDF with nothing, so you compare TDF-FTC dolutegravir with DTG-3TC, again, a significantly smaller rise in body weight. So it seems as if you don't have to compare TDF with TAF, you can compare TDF with not taking TDF, and you get roughly the same result, that you get more of a suppression of weight gain for the people taking this treatment. Now, is there actually a benefit to this? If you look at the consequences of lower body weight rises, and you look at the hepatitis B trials, again, no HIV involved here, people taking TAF are more likely to show grade 3 or grade 4 hyperglycemia and hyperlipidemia than people taking TDF. This is a trend that's seen in a lot of HIV studies as well. And these are the 2 pivotal Gilead studies of first-line TAF or TDF to treat hepatitis B. So significantly more, a higher risk of cholesterol elevations. Then we look at the Emerald study. We take dolutegravir out of this. We look at TDF versus TAF with darunavir, cobicistat. Significantly more elevations in LDL cholesterol with TAF. Significantly more elevations in total cholesterol, and significantly more cases of diabetes. So it seems that efavirenz is driving body weight down, and so is TDF to some extent. Now, on the left-hand side, the last piece of this equation is about what's the effect of low CD4 count and high RNA? Are we seeing greater rises in body weight for people who start with a lower CD4 count? And is this what's called return to health? Is everybody just gaining weight because they're getting healthier? What I want to introduce here is not return to health, but HIV-related weight gain. And it's a new concept, and I'm going to show you how it's actually related very strongly to immunosuppression. The more severe the HIV infection, the more body weight people gain. So let's think about a hypothetical patient. We saw a lot of patients like this in advance. Now, on the left-hand side, think about body weight classically falling during HIV infection when it's not treated. So people show a gradual loss of body weight as the CD4 count falls, and that's been very well described. HIV in Africa used to be called slim disease, where people lost so much body weight as their infection became more severe. Now, when people go on to treatment, we know that the weight should return to a pre-infection level. Now, you could call that return to health. However, what we're seeing in the longer term is an overshoot in weight gain. The weight keeps on rising. And we have this with patients in Africa who initially, they're very happy that their weight has gone up. They say, I'm back to the weight I was before I was HIV infected. I'm really happy with how this has progressed. And that's the first stage until you get to the green arrow. Now, after that, the weight keeps going up, and then they feel they're losing control, and they don't know what to do. This overshoot weight gain is seen in studies of dieting. If you get people who have a normal body weight and put them on an extreme diet, they tend to gain more body weight than they've lost. It's actually a bad thing to do, and this has been described in many dieting studies going back 30 to 40 years. So let's look at return to health or HIV-related weight gain. How do we know which one's happening? Now, we know already that people with more advanced HIV disease tend to have lower body weight. So if somebody has a low CD4 count, they have a lower body weight. So we would expect weight to go up by more, but we'd expect everybody to get to their pre-infection body weight at about the same rate. And we would not expect people with very low CD4 counts just to become obese. That would suggest that it's HIV-related weight gain. Now, let's look at three large studies that have analyzed this question. So again, the analysis of the Gilead studies in Paul Sachs's analysis in clinical infectious diseases, 8 randomized studies, 5,000 patients. So here they saw people with CD4 count below 200 gained 3 kilograms more than people with CD4 count above 200. People with RNA above 100,000 gained 1.4 kilograms more than people with RNA below 100,000. But you could say, well, they had a low CD4 count, so their baseline body weight was probably lower. So they'd lost more weight before treatment, so they're going to gain more weight after treatment. Is that just return to health? Let's move on then to Sophie Grabar and the French hospital cohort database. Now, they looked at a much larger sample, 11,000 people, and they're not just looking at change in weight, they're looking at extreme weight gain, and they're calling that at least a 10% rise in body weight. Now, in the French analysis, people with CD4 count below 200, 2.46 times more likely to get this 10% weight gain. People with RNA above 500,000, 2 times more likely again. But we get the same trends we've seen before with females gaining more weight than men. We then looked at this in the advanced study. So we looked at the people taking TAF, FTC, dolutegravir. Now, these are people who don't have the suppressive effects of TDF or efavirenz. They're taking the drugs, and we're then looking at how the CD4 count at baseline then affects the weight gain. Now, you look at this graph in some detail. The blue line is people who started treatment with a CD4 count under 100. And you can see at the baseline visit, they actually had the lowest body mass index, slightly lower than the other groups. And you can see out to week 96, the weight keeps going up until they have the highest BMI of the 4 groups. And then CD4 count 100 to 200 is in the orange, and they show a slightly less effect, but the CD4 count, the BMI ends up higher than the people starting with a CD4 count 200 to 350. And then the lowest body weight rise is among people with a CD4 count above 350. Let's look at this now in terms of clinical obesity. There's the most extreme form of weight gain. And you can see here that the people with CD4 count under 100 taking TAF, FTC, dolutegravir, over 50% of them become obese after 4 years of treatment. So this is something that hasn't been described in much detail before. This is very much suggesting we have a syndrome of HIV-related weight gain. The more severe the HIV infection before treatment starts, the higher the risk that somebody shows this extreme weight gain during treatment. And actually, it's a strong argument for earlier treatment, which would lower this risk. But we see late treatment still, despite all the measures that have been taken. And you see this is a very linear effect. So the CD4 count below 100, they've got the highest risk of this obesity. CD4 count 100 to 200, an intermediate risk. And then when you get to CD4 200 to 350 and above 350, this risk is less. But we're showing very consistent results to the French on this. So if we try and put all this together and we say, well, if you don't stop this weight gain, you're going to get these consequences. And if people take TAF FTC dolutegravir or TAF FTC bictegravir, or indeed any treatment that doesn't include TDF, they have this higher risk of clinical obesity, which is related to low CD4 count. Now that should then lead in the long term to higher risks of myocardial infarction, diabetes, cancer, adverse birth outcomes, Alzheimer's disease. We're already seeing this with metabolic syndrome. We need longer-term follow-up to see whether this will translate into more severe outcomes. We've done predictive analyses looking at Framingham, Q-risk, cardiovascular predictive equations, and diabetes equations, which would suggest that we should see a slightly higher risk of heart attacks and diabetes with TAF or treatments not including TDF in the future. And remember, across Europe and in Spain, the leading cause of death is cardiovascular. Just one other consequence, if we treat women with TAF-containing treatment and they become clinically obese, there are many consequences for adverse maternal outcomes and adverse infant outcomes, preterm delivery, gestational hypertension, diabetes, preeclampsia, postpartum hemorrhage, C-section, and among the infants, a large for gestational age, macrosomia, neonatal death, stillbirth, and neural tube defects. All of these have been described very well among HIV-negative pregnant women. So I think we need to assume that we could see the same consequences treating long-term with TAF-containing treatment or treatments that don't include TDF, and these consequences if there is then a higher risk of obesity. So the other side of this is where you say, well, there is this risk of obesity with TAF, but with TDF, there's the potential effect on bone mineral density and renal markers. So we've got some scales here. Which one is the worst consequence? So we've seen these effects on clinical obesity very clearly in the studies. The evidence around actual bone fractures and actual grade 3-4 renal adverse events is very poor. There's very poor evidence that this actually is a consequence. There's lots of evidence that there are very small effects on bone mineral density. But in the long term, we've done two very large meta-analyses. We've looked at TDF-FTC versus TAF-FTC, meta-analysis of 5 treatment trials. This is when TDF is not boosted. The modern HIV treatment does not include ritonavir or cobicistat with TDF. If you include those booster drugs and have a high concentration of TDF, then sure, there is a higher risk of renal adverse events. But that's not what we do nowadays. We give TDF with dolutegravir or bictegravir, the same thing with TAF. And there, grade 3-4 laboratory, bone fractures, discontinuations for renal adverse events, no difference. And then even if you compared TDF-FTC with placebo for pre-exposure prophylaxis, the risk of fractures, the risk of grade 3-4 creatinine elevations is just not significantly different. These are randomized studies. And I think we need to be very careful saying there is a higher risk of renal or bone adverse events with TDF when the randomized studies say in the long term, so far there isn't. There are small effects on biomarkers which might not translate into any long-term consequence. So where are we now? I showed the slide at the beginning, and I think now we're seeing when we look at drivers of clinical obesity, that the CD4 count starting treatment is very, very important. People with black women in particular who start HIV treatment with a CD4 count below 100 or 200 have a very significant risk of developing clinical obesity if they take TAF-based treatment, if they take a treatment that does not include TDF. And the TDF could actually be acting to suppress that uncontrolled weight gain, and it actually might be a good thing. The TDF appears to be suppressing weight gain, and we still see greater effects among women and among black people. Now, imagine you've got somebody in your clinic and their body mass index has gone above 30 kilograms per meter squared. They've become obese. What do you advise? Exercise and diet. That's the classic one. Now, the problem with exercise and diet is the more people exercise, the more they eat. And I wish it was that simple. I'll give you an example. So in June, I did the Camino de Santiago. I cycled from the border in France, Saint-Jean-Pied-de-Port, past here to Muxia and Santiago de Compostela, 950 kilometers on a mountain bike. It was crazy. Now, how much weight did I lose in that time? 1 kilogram. My diet went crazy. I loved the Spanish food. It was amazing, but I had so much of it that, so diet and exercise, it might work, but there are actually studies where you put people on certain exercise regimens and they don't lose any weight because their diet changes. So the second thing you can do is go, well, let's switch people from TAF to TDF. So we looked at this at the end of the advanced study. We did the characterized study, and everybody who was taking TAF FTC dolutegravir switched to TDF FTC dolutegravir. And we measured weight, lipids, fasting glucose, etc. Now, what we saw, particularly among the women, you can see the red line on the left-hand side. You can see the rise in body weight up to week 192, 10 kilograms. Once they were switched over to dolutegravir, the weight came down. Much less effect in men, but the effect on weight was smaller to start with, and the sample size was quite small. In addition, the people who switched from TAF FTC dolutegravir to TDF FTC dolutegravir had significant reductions in total cholesterol, LDL, triglycerides, fasting glucose, and HbA1c, and everybody remained suppressed. So this is an option. But you think about the kind of weight loss that we see compared to anti-obesity drugs. There's a lot of talk across Europe, North America about semaglutide, tirzepatide. Now, these drugs can lead to a weight loss of between 13 and 18%. TDF-FTC, the weight loss seen across the studies we've analyzed, is 3%. Now, TDF costs $40. Semaglutide, semaglutide costs a crazy amount of money. We have systems for universal access to HIV treatment. We do not have systems of voluntary licensing so people in poor countries can get access to anti-obesity drugs. Obesity kills more people than HIV, tuberculosis, malaria, and hepatitis combined. We need to have access to anti-obesity medication at affordable prices so that we can treat people with HIV who become obese, if this is HIV-related weight gain. So just to conclude, weight gain is more severe for black women. They're 42% of the HIV epidemic worldwide. Use of TDF or efavirenz are suppressing weight gain, but people with low CD4 counts and advanced HIV disease are at higher risk of weight gain. This is not return to health. It develops into a syndrome of HIV-related weight gain, overshooting, and including TDF in first-line treatment appears to lessen the risk of these extreme weight gains. The World Health Organization guidelines for HIV treatment are very different to the European ones. For the last 5 years, the most preferred treatment is tenofovir, 3-TC, dolutegravir, and TAF is only considered for people with established osteoporosis or impaired renal function. The dual therapy, DTG, 3-TC, is not recommended at all. So the implications of this, think about, we're in 2023, we're at the end of 2023. 3 years and 2 months from now, the patent on dolutegravir will expire. It will start to expire. The basic patent will go worldwide. Now, you can buy a year of treatment with tenofovir, FTC dolutegravir for 40 euros for use in Africa. Prices will fall massively once the patent expires. So what choice do you have? Using TAF, FTC, bictegravir could actually be causing net harm for people who have low CD4 counts at baseline and at a higher risk of clinical obesity, which could then lead to diabetes or cardiovascular disease. Other combinations which don't include tenofovir could also be a problem, using doravir or islatravir or using dolutegravir 3TC. The Spanish budget for HIV treatment is over 600 million euros per year. If everybody was switched to generic tenofovir, TDF, FTC, dolutegravir, the savings would be in the hundreds of millions of euros, which would then allow budget for mass prevention programs, elimination of viral hepatitis, and vaccination for hepatitis B. So that's how I'd like to leave it, and thanks very much for inviting me.
Thank you, Andrew, for your excellent talk. We have 5 minutes now for questions from the audience. Juan?
Yes, Dr. Hill, congratulations, excellent talk. So there is something that I found missing, perhaps I'm not aware, and these data are out. So in this debate, is a return to health or is an HIV-related gateway? What is the weight and the BMI, for example, in the advanced trial of the population that lives without HIV, of the same age, same sex, and same socioeconomic status? So it's to see all this change in weight and BMI, how to compare with a population, let's say, matched but without HIV?
I mean, that's a very good question, and I think that analysis needs to be done very carefully because there's a lot to match. Socioeconomic status is hard to match for. There is an analysis about to be presented that is confidential at the moment that will answer that question, but I think we can't assume that that people are going back to a societal norm. I think we might find that they end up higher, but I can't share the details at this point.
Okay, thank you.
Esteban?
Yeah, thank you for your presentation. Very provocative and also a lot of new data. Do you think, because you have presented the data as TDF and efavirenz are preventing the weight gain that is associated with HIV infection, do you think that, do you minimize the risk that particularly TAF may have synergistically with second generation integrase inhibitors, or do you think they have a role in weight gain, the synergistic effect of TAF and integrase inhibitor, or do you minimize it and it's only a question of switching from TDF to TAF or from efavirenz to integrase inhibitors?
Yeah, so I think efavirenz has an effect on suppressing weight gain. TDF has an effect on suppressing weight gain. I don't know after that if there's any difference between bictegravir, islatravir, doravirine, dolutegravir. It might be that all of those drugs are neutral, but they're neutrally allowing weight gain to continue. So we might have a situation, and we might see this in the next few years, where any treatment that doesn't include TDF, so it could be doravirine, islatravir, it could be TAF, FTC, bictegravir, it could be dolutegravir 3TC, they're all going to lead to this higher weight gain, and we need to be very careful.
Okay, thank you.
So, Andrew, thank you. So I'm asking, the difference between TAF and TDF is very small. The difference is in intranuclear concentrations and intracellular concentrations. Do you have any clue what is the mechanism that tenofovir difumarate is making this weight losing properties?
I have a feeling that there's something to do with appetite. I think it's very hard to measure this prospectively. When we started Advance, we had no idea that this was going to happen. But if there's a significantly higher risk of vomiting in the PrEP studies, I think that's something that needs to be looked at. I don't know if that's necessarily the truth, but if we're altering people's diet in a subtle way, that might be the cause. I mean, the difference between TDF and TAF, TDF has a higher plasma concentration, and it might be that that plasma concentration is somehow affecting people's appetite. Might be.
Thanks for your research and excellent talk. One popular combination now in Spain is switching to long-acting cabotegravir and rilpivirine. My question is, I wonder if you have information regarding the weight gain with this antiretroviral therapy.
Yeah, so in the studies where cabotegravir was compared with Truvada for PrEP, I believe there was a slightly greater rise in body weight for people taking cabotegravir compared to TDF. In the studies comparing cabotegravir with ongoing treatment, I don't believe there's a great difference. So I think cabotegravir could be in the same category as dolutegravir. It's another drug that isn't affecting weight gain, and so if you give it without TDF, then the weight gain could carry on going up for people with low CD4 counts.
Thank you.
Thank you, Andrew. Pasamos ahora a la siguiente charla.